Hello to everybody. This is another one of our regular drop-in sessions now, where we try and cover off a particular topic in a bit of detail. This morning's session is looking at what does a basic health data look like. People talk about health data all the time, but quite often it's difficult to see, and even the data you can see may not be complete. There may be things inside that you're never aware of. And as more and more people are becoming more involved in their health data, I think we thought it was useful for people to see what it is, what health data actually looks like. So let's crack on with this session. What do your health data look like? There are a range of health data types out there. There's a huge amount of data which is directly to do with our healthcare and then associated with our healthcare. We can't cover all these in one session. It's just impossible. So what I'm going to do is try and look in a few cases about a typical pathway of care, the sort of experiences that you or I might have when we're going through talking with our GPs, going through a diagnostic process, potentially going through some treatment, and talking about how data is generated and what it actually looks like. And then some of the difficulties of using that data because of how it's generated. And then we'll finally end up on some of the points about what you can actually see about how your health data is stored and how much of it's being used. And then some things around what might be changing in the future. If anybody does have any questions all the way through, please ask them. Otherwise, we've got plenty of time at the end to cover questions off as well. So just starting right at the outset, I'm not going to cover any of these in detail, but if you just think about the data that's generated with children, younger people these days, there's a large amount of data all the way through maternal health and childhood, which is generated, which just sits there for most people in life and isn't really used particularly because with our interactions with healthcare systems, predominantly as we get towards older ages or particular life events, and pregnancy is a particular life event. But there's a large amount of data which is generated around younger people, children, right from the outset. So even when we're born, we're assigned a number. In England, it's the NHS number, it's the healthcare number in Northern Ireland, and the CHI number in Scotland. They're essentially the same thing. It's a unique identifier which the healthcare systems in these different countries, different parts of the UK, can use to identify us in different sets of data which are collected, which we'll cover in a minute. They are different systems, NHS, HCN, and CHI are different numbers, but the principle is exactly the same. It's a single number by which we can be identified across different healthcare institutions. If you're a younger person, there's a whole set of data which is generated right away from birth. You get an NHS number, an HCN or a CHI number assigned at birth. And then there's other sets of health-related data which is collated all the way through early years, through school-age children, as people then get into younger and teenage adults, lots more data collected. So there's a huge amount of data which is collected, which generally people aren't that aware of, and by and large may not mean anything to you. But as we're looking towards later life, and as the younger people go into their 50s, 60s, 70s, 80s, and 90s and get other diseases and illnesses, the research potential of being able to look back at illnesses and conditions and other factors in early ages could become quite significant. You could look at this in a different perspective. So as well as looking at it from the perspective of younger people and teenagers, you could also look at the different themes of data which is collected. So data on things like breastfeeding for maternal and child health, all the way through to the child measurement, child obesity, oral health, a whole range of different data sets which are collected already about younger people. And this is just the younger people perspective. This is not going on to the typical middle and late age treatment areas. It's just some examples of the sort of data which is collected. If you want to look at any of these data, lots of them are generally published in statistical forms, and I put a link at the bottom which you'll be able to get access to when we put the recording and the slides up. You'll be able to click through and see that, and you can look at all these data sets for your own local areas. And this is the link I've given is for England, but it's pretty typical across all parts of the UK as well. So there's lots of data which is generated, but let's focus from now on what we call consultation to data set, the sort of types of data which get generated about us when we go through a fairly typical diagnostic referral and diagnostic pathway. This is all based on generic sets of circumstances. There are slight differences across the UK, but by and large, it's much the same. So the naming might be different. By and large, it's the same. But I'm trying to demonstrate where the data gets generated, who generates it, and then some degrees of what you can see of it and what happens to it once it's been generated. So it's meant to be a generic presentation. So let me start on the GP. So I'm feeling it poorly. I want an appointment with my GP to look at something which has been niggling me. I can log on to the practice system more and more these days and make an appointment directly, or I can phone them up and ask for an appointment. Or there are other intermediary systems which people can get access to as well on your iPhones and other things, which the GP practice subscribes to, which makes life easier for you and I to get access to an appointment. All our details are already on the GP practice computer system, as long as we're registered with them. And if we, incidentally, if we move practice, that data also gets transferred from one practice IT system onto another. That used to be quite a long process. It's much more slick now, although I believe it's not perfect. But when you look at the GP practice systems, what has changed over the last number of years is that the picture on the left with the notes has largely gone away. You remember walking in the practice and they got banks of notes behind the practice staff. That's largely disappeared because what GP systems have done over the number of years is they've heavily gone for computerization. So very few paper notes will exist, real-time paper notes. There'll be some historic ones which are archived, but by and large, GP systems have moved fully onto the IT electronic data world. So if you were to look at your GP record, there are sets of things which are on there which you would expect. So there's contact details about how the GP practice can find me. They've got other recordings about my physical characteristics, my height and weight, allergies, vaccinations, medicines I'm taking, any previous illnesses or diagnoses which I've been diagnosed with, any operations, any other sort of key clinical conditions, tests that have been done. So it's a huge chronology of how the GP practice has engaged with my healthcare, the things they've asked to happen, and results from things they've asked to happen, even if those things haven't happened in a GP setting. Hospitals, for instance, I'll come back to that in a minute. It also records lifestyle information about smoking, alcohol, exercise, and other things. Those are as described by us, and one of the concerns is how accurate those things are. So if a doctor says, how many units of alcohol do you drink per week? People tend to err on the low side. So from a research perspective, researchers, if they ever want to use this data, need to be aware of that. That's around data quality. If you're interested in more detail about what's in your GP record, there are a couple of nice guides. Well, that one's from England, the second one is from Wales. Both are really sensible, useful guides. There are other ones in Scotland. I just didn't have time to dig them out. But when you get the slides, you can click on these. You can link straight through to those two documents. They're quite good summaries. So let's look at the detail of a GP record. This is me. This is my GP record. So I logged on to the GP system with my NHS number and password, and I was able to access all the information about me that's on my GP practice system. I did this about a year and a half ago, I think. And it shows you a summary of things that have happened. For instance, it gives you a date about when something has happened on my GP record. It tells me who has made that change to the record, and it tells me what that change was. In this case, this was to do with the COPI regulations, the regulations which were enacted to enable data to be used in response to the COVID pandemic. And this is just a reflection on my record that said the data from my clinical record was uploaded to the central COVID database under the legal permissions of the COPI regulations. So quite detailed information on there about where data may have been used. Other things, for instance, I go back in time and I was referred for a test result, for a test, and the test results came back to the GP system. There's a summary on there of what those test results were and what was done. But these were tests which were done in a hospital setting. So immediately you've got the information recorded on the GP system, and you've also got it reported in a hospital system as well, which we can look at later. But there's quite a lot of detail in there. You've got the summary details, but you can also, if you wanted to, view the individual result. So if I'm so inclined, I can go through to my GP system and I can see a full details of the full pathology text that's in there as well. So quite a lot of detail you can see, and that's actually the full text. So this is me looking in my record. A few things to note. The boxes on the top are essentially coded data, structured data, so that a clinician has viewed this result on the 4th of June 2019. So from a computer system, that's very easily understandable. If you look further down to the bottom, it all comes out as a fairly splatter-free text. Now that's unstructured. In fact, this is semi-structured data. Now for a computer system to analyze that, to look at outliers in terms of ranges, it would need to have a fairly complex understanding of how those texts are put together. And if it is free text, if somebody puts an extra space in, an extra comma in, then it messes things up. And this is the difference between structured data, coded data, and unstructured data, which is largely what this is. You might find that the lab system that generated this records the data, the codes, the variations, the values in coded format, structured data, but it throws it into the GP system as a text file, unstructured data, and there you can find the differences. So when you hear a researcher, for instance, talking about wanting to use unstructured data, these are some of the difficulties they encounter. And if we do a session later on big data and artificial intelligence, that's where artificial intelligence begins to look at natural language processing, for instance, begins to look at how you interpret text and turn it into useful analyzable codes. So you'll see there's some structured data there in terms of dates. The provider sample, that's a code which links back right the way to the lab system in the hospitals. So you can link the data together, and then the structured data, the results are in there. Another variation, this was another test I was sent for. You're doing my full medical history here. This was a problem I had with my ankle, and it's a different set of data that's come through, but there are some common things in there, where it's come from, what the test was, what date it was done, what the result was, and then again, a set of free text. I think to look at here is there's lots of question marks in there, halfway down, question mark OA left ankle, question mark stress fracture. Now, some of the early natural language processing systems, the computer systems that try and turn text into codes, got confused by the question mark. And I saw some of the early ones that said question mark breast cancer, for instance, would immediately come up as a potential breast cancer case and would be extracted and thrown into the cancer registry. That created a fair amount of work. So that's where things like artificial intelligence and natural language processing need to be far more sophisticated to understand nuances like question mark. So that's what data actually looks like. This was a pathology text. This was the wording, the free text that was sent by my GP to the hospital and recorded in the hospital systems. That was the query. So back to your GP system, data which is in your GP system comprises two parts. One is text data, free text data. And you'll see when you're in your consultation with a GP, they'll start madly typing free text data in there. Equally, they'll code things as well. And the coding systems which are used in the GP systems are based around READ or something called SNOMED CT as well. It's a clinical terminology system. So instead of using code 1, 2, 3, it goes down sets of clinical conditions and breaks them down to more and more detail. And this is a very, very simple example of symptoms, respiratory symptoms, cough, and then different categorizations of cough. So when a GP and the clinical staff in the practice are recording things like this, they try and codify things by using this terminology-based system. And there are tens of thousands of these in the system. But it's readily understandable from an English perspective. So that's what the primary care system does in terms of recording in its own practice. Of course, then if you go to see your GP with a particular condition, they then need to refer you through to the hospital normally. And that comprises different things. You've got the electronic communication system. So the practice system can communicate electronically with the hospital system. That's becoming more common, but it's not across the country by any means. There can be phone calls involved, letters and secure emails are often used. Fax is not these days. I think those have finally died out, but that did used to be fairly common across the NHS. Only a few years ago, it was noted that the NHS was the largest purchaser of fax machines in the world because we still relied on them. That's by and large is gone now, thank goodness. Of course, when a GP makes a request to the hospital, that data is immediately replicated in the hospital system. You'll hear a lot of the time about data being replicated or copies of data or the same data being recorded twice. That's because the two systems are different. So the GP system needs to know what it's referring you to the hospital for. The hospital system needs to know what you're being referred into the hospital for. That data exists in both places. If that data ever gets out of step, if somebody at one end modifies it for whatever reason, the other side of the equation might not get modified. And from a research perspective, or even your perspective, when you look at your records, that's why you can sometimes see differences in what it says in your GP record, what it says in your hospital record. That's fairly common across the NHS. And then finally, the hospital creates an appointment for you with the date and time and the clinic and where to go and the various instructions. And that's usually transmitted to you in form of a letter, and that letter usually goes back to the GP system as well as a free text copy rather than a coded copy. Again, useful for them to read and see, not particularly useful from a research perspective if you want to analyze things using codes at a later date. Same thing again, structured data is things like dates, time, things like that would be structured data. The unstructured data would be things that are included in a letter, free text, handwritten stuff, which is very easily understood by a medical professional and by us, but very difficult for a computer system to understand when it's trying to analyze things later on down the line. So again, simple examples of structured data and unstructured data. So then you arrive at your hospital. You go to your hospital for your appointment. And the first thing they say is, what's your name? What's your address and date of birth? And a lot of people say, why on earth do you keep asking me this? Because you know this every time I get asked, what's my date of birth? Well, there are good clinical reasons. First of all, the front desk team need to know that you are who you say you are, and they've got the right person. So it's a basic safety issue. Anybody coming from an accounting background will have been very, they'll have worked on the concept of double entry bookkeeping. The left and right need to balance. It's the same thing here. So when people use the phrase, we will collect data once, it's slightly naive because you don't. You need to collect data or verify data throughout the different clinical pathway. It's a basic safety issue. So when people say we should only collect data once, I immediately get slightly irked about that because the financial systems of this country have always been based on double entry bookkeeping, and that collects data twice. And the same principles would apply here to improve the data quality. And when you get poor data quality, as you'll see in a minute, you get problems. So the hospital clerks check your details and record you as an attending at the hospital. And then all this information gets recorded in your hospital record. These are not your typical hospital records, but you will have seen these, no doubt. The left-hand side is the typical old-style paper-based record, and there are lots and lots and lots of those still in existence, still in active use around hospitals across the UK. But equally, you'll see more and more medical records on computer systems within hospitals being used more. This is not a perfect scenario. There are still, whilst where primary care has dropped its reliance on paper, its use of paper to go to fully electronic, hospital systems have not yet been able to do that across the UK. There are some which do, but many which don't rely on it and rely on a hybrid. So that hasn't gone away. So when I talk about your hospital record, the other thing to realize is that the hospital itself might have different IT systems in which your data is stored. You'll just remember the pathology report that came back from my X-ray. That was generated from a pathology system in a hospital, which is part of the suite of hospital systems which make up the hospital medical record. Some of which communicate between themselves very well, some which don't. So your data can find itself in a hospital in 3, 4, or 5 different systems, even if it's seen as the same hospital record. And again, this is where you begin to see problems with the NHS across the UK trying to manage at an individual hospital level. And now, even more so, hospital records have been combined, whether it be through the process of NHS Trust generating data between themselves because of multiple hospitals joining together to provide services. We've got hospital networks generating care plans for patients, and they need to share their records, but all those records are in different places. Now we've got things like integrated care systems which have been set up. And again, the data to help those, the data about you and I for the integrated care system might sit in 10, 15, 20 different hospital systems and parts of hospital systems. And this is why the NHS struggled with this for so many years. It's complicated stuff. But the data gets into the hospital record normally by people typing it in, whether it's the medical record staff, the front desk staff, or indeed sometimes by the clinical teams directly. Some hospitals share the same systems, some have got different systems. So the data needs to flow between the two of them or between multiple systems, which indeed increases replication of data. Your data might sit in 4 or 5 different systems. And then you've got other systems which are just slightly different and not text-based, such as image systems. So we'll have seen more, actually you've probably seen it yourselves, in just a few years ago, if you went for an X-ray, the X-ray would be read by somebody slamming up an X-ray film, a slide on a viewer and looking it through a light box. These days, that's largely gone. It's all been replaced by electronic versions of X-rays, medical imaging, but those require a large amount of computing space to store, but they're incredibly good in terms of being shared, much more accessible to clinical teams. A single CT scan, I'm guessing at this, is around about 30 megabytes. There are differences from different systems and it depends on the resolution, but because the NHS generates loads and loads and loads of these, it's a huge amount of data storage space, which is used to physically store these images. That's why we have image banks now being used rather than individual hospitals having to record and set up their own massive computer systems just to store the images. You could probably get single CT scan, you probably get 400 of those on an iPhone, give you some idea of the scale, and then it's full. Given the volume of these things that the NHS goes through across the UK, there's a vast amount of data which is generated. Interestingly, when I started working on computer systems back in the 80s, when a clinician or the hospital staff were using the IT system, the clinical system, the data was restricted to around 16 kilobytes that was available to them, 16 kilobytes. So a single medical image around 2,000 times bigger than the entire medical record somebody was looking at back in the 80s. So the scale has gone up massively. So as with GP systems, your electronic data in hospital systems is held largely in codes, but there's huge amounts of free text because it's easier for people to read, easier for people to understand. The codes, however, are easier to analyze. So if you're trying to extract people with a particular condition, you tell your computer system, look for anybody with code 123 in this field, and it will find them. When you begin to compare your hospital record with a GP record, you'll notice there are fundamental differences because they use different coding classifications. So the GP system use that that terminology system, whereas hospital systems use a variety of things and different variants of things, and they're largely based on classification systems, disease classifications. And that's where you'll see things like ICD, International Classification of Disease codes used, which are comparable across the world, but don't exactly map onto GP systems from a hospital perspective. So there are some inconsistencies in the way data is generated across primary care and secondary care, your GP and your hospital. There are also lots of different treatment codes for different types of treatment. So there's a set of coding systems which are used for surgery, which are across the UK largely. There's sets of codes which are used for chemotherapy and for radiotherapy and for all sorts of other treatment conditions as well. All those require different coding systems and they require them to be adhered to. So when we talk about coding systems, here's one example. This is an International Classification of Disease coding system. This is used in hospitals across the UK. And this is just one extract from a book, which is several hundreds of pages long, where all these codes are defined. These are internationally defined, international comparable, in this case for breast cancer. And that's what lets you record, this lets you record robustly across the UK for what conditions people have been diagnosed with. It also lets you compare robustly across the UK and indeed across the world as well. This is where coding systems become very useful. But you'll see there's a rough breakdown of the coding systems which are used in there. And similarly, where you're looking at this is I forgot what this is. This is procedural systems. I think there are further coding systems which are defined within the UK, which are not internationally comparable. So OPCS4 codes it's been used regularly across the UK, but they're not comparable directly with other countries. And then this one is a different set of coding systems. This is fairly typical. This is an actual record, actually, of different codes which have been used for diagnosis, for morphology, for different types of things being done within individual, all the way through the system. So when you're looking at somebody's record or your record, this is largely what a clinical team would have access to: coding systems, dates, lots of yes and no's, lots of ones and twos. And from a privacy perspective, people might find that confusing, but they also might find it reassuring that what you don't see on there is name, address, date of birth, and the rest of this. So this will be called a de-identified part of your record. But it's all very well structured, very well defined. There are clear NHS standards for defining and recording any types of those data, so you can do comparisons. There's one slight difference in that if you're on a clinical trial, the data standards for that trial are defined really for the trial. So for instance, instead of the NHS number, they tended to have participant numbers. So immediately you've got the problem of being able to connect the data from the clinical trial patient with the data from which is collected as part of routine NHS care. The other difference you'll have in clinical trial data is there's a data of informed consent. Now, all the health data that's been generated about you, you will have consented to treatment, you'll have consented to investigations, but the data which is generated as part of that is being generated because of your direct care. And it's used later on down the line with a different legal basis. Trials are fundamentally different. You need to have informed consent to collect your data and use it for that particular trial. And that's where you'll see differences in the problems researchers have access to, trying to get access to trials data plus routinely collected healthcare data, because they're collected and stored and used with quite different legal basis. The other thing that trials can do is they can collect data which isn't routinely collected. That one says, did you have malaria in the last 20 days, which is particular to this trial. It's important to this trial, but isn't the sort of thing that you get asked when you waltz in for your X-ray on your ankle in a local hospital. I didn't get asked, have I had malaria in the last 28 days, because it's not important. So trials can collect different and additional sorts of data. And there are problems when you're trying to compare the results of different trials data, because they may have used different coding systems. They may have classified things. So one trial might say, have you had malaria in the last 28 days? Another one might say last 30 days or last 2 weeks. So there's subtle differences in the way trials data is generated, which sometimes makes it difficult to use to compare one with the other. The other thing to think about in terms of your data is the NHS does deal with us as individuals, but it also deals in activity data. It tries to group things together to make sense of. So you'll hear, if you're working with health data, you'll hear lots of things about group data, activity data, episode data. And that's because it's the way the NHS deals with the problem of having to link data together from different systems to build a pathway of data for our care. And it has lots of difficulties doing that, and it's an imperfect science, I have to say. But it generally tries to build episodes or groups of care from all those bits of data it generates about us through our different parts of our care pathway, all of which can come from different systems and different coding groups and different organizations. One example, this is an example of a cancer pathway. So along the bottom, you've got a fairly typical route: primary care, you get perhaps referred through for a screening episode. There's a diagnosis process if you have a lump or something odd is found. If it's a positive diagnosis for a particular type of cancer, you'll go through different sorts of treatments, and then you'll go through areas where we're looking at your the health impact of having that particular condition, that treatment, and then potentially into things like palliative care. So that's a typical pathway for cancer, very generic. You could apply it to other diseases. It would apply to things like cardiovascular disease without the screening bits in there. But along the top, you'll see there's all different sorts of data which has been generated just in this case for cancer. And this is a very, very, very simplified model. So the same thing applies for diabetes care, for cardiovascular care, for cystic fibrosis care. All the different principles apply, that lots of data is generated across the pathway, all in different places, all the different types. And that's why the NHS tries to pull these things together as episodes of care to try and make sense of it. So another angle of your healthcare data is, can you see it? Now, clearly you can see some of it because I've shown you some bits of mine, but what is it that you can actually see in your GP system or your hospital record? I'm just sticking with GP and hospital systems at the minute. I know there's other healthcare data out there, but for reasons of time, I'm sticking with those two things. So what can you ask for? And indeed, what are the difficulties of getting access to those different sorts of data? So one of the things you can do is you can ask. So this is what happened when one of our patients asked to see the data that was held about them for a particular clinical condition they had been through. And this is actually what they were sent. This is a copy of some of the forms that were sent. So you can ask to see the data, and it's not awfully useful because lots of it comes in codes. You see at the top, they use these things about episodes. So you and I won't have any concept of what an episode is, but it's where the NHS structures the data, and it's given us back our own data, and they've grouped them in this case in terms of episodes. So these are basic things that we can ask for, which are available to us if you ask for the data back. But it's sometimes difficult to understand because a lot of it's coded. You'll notice in this case, the patient who brought this also scribbled some notes on the right of that, which was to do with inconsistent coding that they spotted in their own record. Now, that hadn't been spotted by the clinical team. It may not be clinically relevant, but the fact that the patient had seen it, they spotted this, and flagged that there were some inconsistencies in the record recorded, in their data recorded in the hospital system. Other things that we saw when this person went and asked for a copy of their medical records was in yellow, they didn't know what that was. Didn't have any recollection of having anything to do with their skin or head and neck or anything to do with that. So they queried that. Now, this wouldn't have been spotted by the clinical team because it's done, it's happened, it's in the past. This person's come out of their care. But from a research perspective, this is only spotted from a patient looking at the record. And if you're a researcher getting this access to this record to do some research, you won't know if it's right or wrong. So there's some real benefits in being able to see your own record, not least because you can see if there are inconsistencies in there. And you'll see scribbled down at the bottom, you've got some other question marks about what that was and why it was recorded as such, just to try and understand how this person's treatments were relating to what's in their data within the hospital. So it's not awfully easy at times. This was, in fact, another patient who went into even more detail and got access to their full, in this case, this was a lymphoma they were diagnosed with. They got access to the full clinical record here. And this is just the start of it. I'm sorry, it's a bit fuzzy because I have to scale it up because it's quite a large document. But on it, you can see who they were. You can see where they were diagnosed. You can see what the diagnosis was. And if I skip through the next screens, it goes into more and more detail about what was happening. So this thing, it's a summary of the sort of the clinical summary for some of the cancer treatment. And if you clicked on that, you can see more details. So this, in this case, also had a pathology report, which was done at a particular hospital at a particular time with a particular code, so you can track back the hospital. And this would let the patient, in this case, go back and click on that and say, what was that detail? And you'll see a strong similarity in my own pathology report for my X-ray on my ankle. This is the same principle for a much more complex set of tests which were done, in this case for cancer, but the structure is the same. It's dates, it's times, it's codes, but then you can also click through, and similarly, there's lots and lots of free text. So this is the actual free text for somebody who's been through this process. He's given us permission to use these, actually. We've used these in several presentations in the past. But you'll see the same sort of structure. It's all free text. It's unstructured data, although it's semi-structured because you could understand it, the specimen, the clinical details, the macroscopy, the microscopy, and then some codes underneath. So you could probably try and make sense, but it's not immediately understandable by a computer. That's why things like artificial intelligence and machine learning, natural language processing, the ability for computer systems to understand free text is becoming more and more important. So I mentioned that the other point about the benefits of being able to see your own record, you can spot things which you know are incorrect or need to be questioned. We've done this a few times with a few different people, and the most recent one, which is the one I just showed you, was better than one we did, well, knocking on for 10 years ago now, 9 years ago, where we did a similar exercise with a guy called Tom. There were lots of oddities within his records. So what we were trying to demonstrate was whether the NHS is improving its coding of data, its quality of the data being recorded. And from the anecdotal test we've done, the answer was yes. There's lots more data in there, and there seem to be lots fewer inconsistencies. There were some inconsistencies in the most recent record we looked at, including differences in inconsistencies in coding. Some data was missing. There was a whole set of chemotherapy data missing from one person's cancer record, which they knew they'd been to, as you would, but it wasn't recorded in the clinical record for some reason. There was some erroneous code and some other things. But largely, they thought nothing of massive significance apart from that one item. So they were quite happy with what was in their record. It was quite accurate. And that's a positive for the whole area of data quality, which the NHS has been trying to improve for many years now. The other thing which we found when we did the subject access request was, and this is around a hospital setting, we found that 2 organizations have been supplied with the data, personally identifiable data for this person, on 3 occasions to do research with. And the depersonalized data, 8 organizations have been given access to data on 18 occasions from data from this record, but without the personal details in it. So they couldn't tell who the person was. But it just demonstrated that when you ask, there's lots of information that's out there about how data has been used by different organizations outside of our direct care. And that's something, again, is becoming more and more important. They also found in this case, because it was cancer data, the data had been used extensively by the cancer registry analysts inside the registry, inside the NHS framework, as you potentially might expect. So that also raises the question about, well, choice. If the data is being used outside of your direct care, what choice do you have about what uses are made of that data? So there's lots of data which is used from GP systems. GP systems feed into, not all, but most feed into research databases, which you may or may not be aware of. That lets observational studies happen, it lets clinical trials happen, lets other things happen as well. GP data, your GP data is also used to drive payments for GPs. So GPs are contracted service within the NHS. They need to be able to pay for activities that they undertake, and your data drives those things. Not the identifiable data, but the group data. And similarly, the GP data is most recently fed into the summary care record, which is the one I showed you on mine, where my data have been fed through to in response to the pandemic under a legal framework. And you'll see that's, if you logged onto your own GP systems, you'd like to see that as well. That drove things out the shielded patient list, which again wasn't perfect because there were some areas of data quality which were affected, which it got affected by. But this is what led to the production of the shielded patient lists at the start of the pandemic, where people said, you're a particularly vulnerable person, we'd like to support you to stay at home. That's how that happened. It can also be used to drive other emergencies were they to happen as well. So that's how your data would be used. And if you log onto a GP system, as I did, you'll be able to see what the policy of sharing in and sharing out is for your GP system, which in fact includes your GP records. And you can make a choice about that on your GP system if you choose to do so. The second one is around data choice about what happens to data in the hospital setting. This is slightly different because this is different across the UK. So you do have an opportunity, a choice to say, I don't want my hospital data to be used beyond my direct care. I don't want it to be used for research and analysis and planning. But that's very difficult to enact in most parts of the UK. In England, they have the national data opt-out, which in itself isn't perfect and can confuse people. But in other parts of the UK, that doesn't exist. Although in legal terms, you do have a legal legal rights with to say you don't want your data to be used outside of your direct care, but it's done slightly differently in different parts of the UK. So that was a very quick rattle through of health data, how it gets generated, the differences in primary care and secondary care, some of the difficulties in different coding systems, pointing out where some of the areas of data quality are not great, and I think those are best spotted by us as individuals. and the fact that you can still only see a small amount of your health data, but if you go through the processes, you can see the whole lot, but it may not be particularly easy to understand. And I think I was going to pause there for questions.